Good afternoon, dear students. I'd like to congratulate you on fourth year of your education. Yes, and this year we have a new discipline that named internal medicine, including endocrinology. And according to quarantine, you know that part of classes we still have online and including lectures. All lectures of this semester we will have online. And we start exactly from endocrinology, and first our lecture is essentials of diagnosis, treatment and prevention of major endocrine diseases. It is diseases of thyroid gland and goiter. Plan of our today's lecture. It is to give definition to disease of thyroid gland, epidemiology, mechanisms, classification. We will discuss clinical presentation, diagnosis, treatment, prognosis, prophylaxis, abbreviation, and we will get some diagnostic guidelines. Okay, definition. Diseases of thyroid gland result from primary or secondary autoimmune in 80% of all cases and from non-autoimmune 20% of cases processes that either stimulate the overproduction of thyroid hormones, we name it thyrotoxicosis, or opposite situation cause glandular destruction and hormone deficiency that we usually name hypothyroidism. In addition, benign nodules and various forms of thyroid cancer are relatively common and are amenable to detection by physical examination. All of them have a large range of symptoms and affect all ages of patients. Goiter. What is the goiter? It is term from American English or another name goiter from British English. It goes from Latin guteria or struma. It is a swelling of neck or larynx resulting from enlargement of thyroid gland or thyromegaly that is not functioning properly. Worldwide, over 80% of cases of goiter are caused by iodine deficiency. Okay, here are some epidemiology data about diseases of thyroid gland. Its prevalence of thyroid dysfunction in adults ranges from 1 to 10%. In all world, it is very often disorders. About 200 million people in the world have some form of thyroid disease. Women are more susceptible than men. Male ratio 4 to 1 from another from different countries. It can be 5 to 1 and even 8 to 1. The incidence of thyroid disorders increases by age. Okay, here is epidemiology of one of the most often problems. It is iodine deficiency. Nearly 30-40 years ago, it was the most important and most often problem in all world according to thyroid disorders. And for today, from starting of taking of iodinized salt, in most countries, this problem reduced in a big degree. And in this map, you see the countries that classified by iodine nutrition according to degree of public health importance. Inadequate iodine intake for today just was found in 32 countries. Adequate in 71, more than adequate in 36, and excessive in 11 countries. Okay, risk factors for thyroid disorders or diseases of thyroid gland. First, it is gender. Women are from 6 to 8 times, what we told, more likely than men. With increasing of age, we usually see increase of risk of thyroid gland, usually in the more sensitive people after 50. It is personal history of thyroid disease. It is family history of thyroid disease. It is thyroid surgery or hypothyroidism. It is radioactive iodine treatment, cigarette smoking, especially for autoimmune thyroid disease, and use of iodine or supplements containing iodine, risk of autoimmune thyroid disease, hypothyroidism and hyperthyroidism. It is another problem that today we have with iodine intaking. On the one hand, it is still actual in some regions, not in all regions, problem of iodine deficiency. But at another hand, the excessive intaking of iodine can worsen, and it is additional risk factor for autoimmune thyroid problem. That's why using of iodine or iodine supplements is very special, and you have to be attentive like a doctors with using of these medicines. Okay, on another hand, what we told, it is iodine deficiency. It is certain medical treatment and drugs. For example, Compat 1H drug. It used for chemotherapy. It is bone marrow transplant, lithium and amiodarone usage, etc. It is eating of some food, for example, cabbage, Brussels sprouts, broccoli, turnips, rutabagas, kohlrabi, radishes, cauliflowers, African cassava, millet, kale, and soy. It is radiation exposure. It is increased risk of autoimmune thyroid disease and cancer, both of them. It is distress. It is neck surgery or trauma and other factors. As for goiter, the risk factors nearly the same, but a little bit other. Let's stop on it. It is lack of dietary iodine. Here, the most important deficiency, then overdosage. In short supply, and where people don't have access in some countries, in some regions, to iodine supplements. It is being female, it is a risk factor for goiter. It is age, chances of developing a goiter increase with age. It is personal or family history of autoimmune disease. It is pregnancy and menopause. It is certain medications like immunosuppressants, antiretroviral therapy, and amiodarone and lithium, as in previous classification. And risk of goiter increases with radiation exposure too. Etiology, yes, of diseases of thyroid gland. Diseases of thyroid gland sometimes result from inappropriate thyroid stimulating hormone levels or may be caused by problems in the thyroid gland itself. The common causes of hypothyroidism are Hashimoto's thyroiditis, iodine deficiency, pituitary or hypothalamus problems. The common causes of hyperthyroidism are Graves' disease, toxic nodular goiter or toxic thyroid adenoma, and thyroiditis. 4 types of thyroid cancer can be present in patients. It is papillary cancer, follicular cancer, anaplastic, or medullary cancer. Most of thyroid cancers are associated with radiation treatment to head, neck, or chest. A genetic mutation might be associated with thyroid cancer, either alone or in conjunction with other types of cancer, like multiple endocrine neoplasia, BRAF gene mutations, etc. Other cancers might be metastasized to the thyroid. The most often it is lymphoma or breast cancer. Here you see a picture of patient with a goiter. It is significant enlargement of thyroid gland, like in this patient. Goiter, by etiology, refers to a condition where the thyroid gland enlarges in size. We talked about it. Goiter can result from autoimmune, Hashimoto, or Graves' disease. Additionally to it, more rare, it can be iodine excess or deficiency and nodular thyroid disease. It is the most often causes of goiter. The most common cause of goiter is iodine deficiency, usually seen in countries that do not use iodized salt, what we told previously. Additionally to it, selenium deficiency is also considered a contributing factor. And connecting, for example, to Ukraine, selenium deficiency for today is even more often and more important than iodine deficiency in etiology of goiter. In countries that use iodized salt, Hashimoto thyroiditis, it is the most often disorder of thyroid gland in general. It is the most often problem. Goiter can also result from cyanide poisoning. It's usual for some tropical countries where people eat the cyanide-rich cassava root as the staple food. Yes, here you see a photo of this plant. Mechanisms. Yes, let's remember a little bit physiology to connect it with pathophysiology of thyroid disorders. Here it's very important because on these physiological links it is diagnosis, it is based your future diagnosis. Let's remember, TSH regulates thyroid gland function and hormone synthesis and release. The pituitary secretion of TSH in turn is influenced by releasing factor. We name it thyrotropin releasing hormone produced in hypothalamus. The secretion of both TSH and TRH is regulated by negative feedback from thyroid hormone, predominantly T3, from the circulation, or T3 that it produced locally from intracellular conversion from T4 to T3. Let's stop. If you don't remember this mechanism, I told more about them in Propaedeutics lecture previous year. Yes, you can find this lecture in my channel on YouTube, and here it is more information about what is negative biological feedback in thyroid regulation. Yes, it is local humoral factors. Here you see a full scheme of interactions between thyroid follicular cells and immune system, because we told that autoimmune system in most countries, in countries without iodine deficiency, it is the most often problem with thyroid gland. And I remind you, it is from 1 to 10% of all adults in the world. Yes, it is every 10 person in the world. Classification. According to International Classification of Disease, it is fourth chapter Endocrine, Nutritional and Metabolic diseases and disorders of thyroid gland, different nosology, named from E00 to E07. Okay, classification by goiter morphology. Regarding morphology, goiter may be classified either the growth pattern or as the size of the growth. According to growth pattern, it can be uninodular goiter, can be either inactive or toxic when we find just one location, one place of pathology. And it can be multinodular goiter when we see nodules or some structures in different points. It can be likewise an inactive or toxic too. Diffuse goiter, yes, it is a symmetrical enlargement of all gland. We can divide by size. It can be class 1 size. In normal posture of head, it can't be seen, or it's only can be found by palpation. Yes, palpatory, you can determine enlargement of thyroid. In class 2 size, it is visible enlargement of goiter, and you can confirm it by palpation. And class 3 size, in when the goiter is very large and it is retrosternal, and it present obstructive syndrome. It is signs of pressure in compression max. World Health Organization goiters grades a little bit other classification by according to its size too. Grade 0, it is no goiter presence is found. Thyroid, it is impalpable and invisible. Grade 1, it is neck thickening is present in result of enlarged thyroid, palpable, however not visible in normal position of neck. The thickened mass moves upwards during swallowing. We often always ask patient to swallow during thyroid palpation. Grade 1 includes also nodular goiter if thyroid gland remains invisible in this patient. And grade 2, it is when neck swelling visible and in normal position. It corresponding to enlarged thyroid found in palpation. And example of grade 2, you see in the picture. Oh, sorry, it is grade 1 type A bilateral goiter. Yes, on picture A, you see craniocaudal extension of the substernal goiter. And on picture B, it is substernal goiter with bilateral extension. And on last two picture, it is substernal goiter with bilateral extension at the level of thoracic inlet. Okay, inflammatory forms, morphologically inflammatory forms of thyroid disorders. First, it is acute thyroiditis. It is not very often found, but it is quite possible. Usually, it caused by bacterial infection, fungal or parasitic infection, is an immunocompromised host. Second, it is subacute thyroiditis. It is more often than acute. The most common of them, it is subacute granulomatous form or thyroiditis of Decker-Van by author. It can be silent thyroiditis. It is subacute lymphocytic thyroiditis or painless thyroiditis. Next form, it is radial thyroiditis, or in other names, radial struma or immunoglobulin G4 related disease. It is one of the manifestations of an inflammatory chronic systemic multi-organ disease. Palpation of thyroiditis refers to the development of thyroid inflammation due to mechanical damage of thyroid follicles by repeated palpation or surgical manipulation or in neck area. It is caused why during palpation we always have to be very, very soft and polite with thyroid gland, because you are not sure is it present inflammation or not, and if it, for example, not present inflammation, too hard palpation can lead to some inflammation and even for thyrotoxicosis and even for thyrotoxic storm. Okay, forms of clinical manifestation. It can be functional disorders. Two main syndromes with thyroid problems. It is two functional opposite situation. First of them, it is hypothyroidism. The most often form Hashimoto thyroiditis, or rare, it can be orthothyroiditis, post-operative hypothyroidism, postpartum thyroiditis, silent thyroiditis, acute thyroiditis, iatrogenic hypothyroidism, thyroid hormone resistance, and euthyroid sick syndrome. And the opposite situation, it is hyperthyroidism. The most severe form, it is thyroid storm or thyrotoxic crisis. It is autoimmune Graves' disease. It is toxic thyroid nodule, toxic nodular struma or Plummer's disease. It can be Hashimotoxicosis. Nodular abnormalities and other forms. It is goiter when we pay attention to size of gland, to enlargement of gland, and it's not connected to the function. Yes, it is enlargement of gland that we named goiter that can lead to some own symptoms. Yes, it is visible enlargement or it's obstructive syndrome due to pressure to some neck structures. And I told you on propaedeutics that size of gland and function of gland are not connected to each other at all. It can be a very enlarged gland with hypothyroidism, with hyperthyroidism, with normal function, euthyroidism, or it can be normal size or small gland with thyrotoxicosis, hypothyroidism, euthyroidism. That's why these two syndromes, size of gland and function of gland, not connected with each other at all. Okay, another situation we can remember about possible tumors of thyroid gland. It is thyroid adenoma, thyroid cancer, lymphomas, and metastasis from elsewhere. It's rare but possible. And it is thyroid problems due to some deficiencies. Yes, it can be due to congenital hypothyroidism, which untreated can lead to cretinism. Okay, classification according to goiter morphology. Regarding morphology, goiter can be classified either as growth pattern or as the size of the growth. Growth pattern. Okay, we had this classification. It is one more time the same clade: uninodular and multinodular goiter and diffuse according to classes. Let's repeat: class 1, class 2 and class 3 sizes of diffuse goiter. Okay, clinical investigation. What are typical symptoms and signs we can find in patients with thyroid disorders? Yes, usually they are connected with function. Is it hyperthyroidism or hypothyroidism? In some cases, that can be absolutely opposite to each other, but some of them the same for both situations. What the main of them? It is nervousness and tremor, more often for hyperthyroidism, mental fogginess and poor concentration for hyper and hypothyroidism, menstrual changes for both hyper and hypothyroidism, feeling bloated more for hypothyroidism, racing heartbeat for hyperthyroidism, aches and pains for both situations, weight gain more for hypothyroidism, high cholesterol levels for hypothyroidism, heat intolerance. It is more usual for hyperthyroidism and feeling cold for hypothyroidism. Okay, let's talk more detailed on hypothyroidism. One more time, what can we find during objective examination and interviewing of patient? It is coarse and dry hair loss, confusion or forgetfulness, often mistaken for dementia in seniors. It is constipation, depression, dry scaly skin, fatigue or feeling sluggishness, increased menstrual flow in women, intolerance to cold temperatures, irritability, muscle cramps, slower heart rate, or it can be increased heart rate. It can be due to tachyarrhythmias, paroxysms of or extrasystoles. Often patient can complain to the increased heartbeat or palpitations. That's why do not make mistake. Palpitations can be like in patient with hypothyroidism as in patient for hyperthyroidism. Additionally, it is weakness and weight gain. As here you see the typical face of patient with hypothyroidism, or another name of this syndrome, myxedema. Yes, it is characterized by dry hair, coarse, sparse. Lateral eyebrows are thin. It is periorbital edema, and it usually finds a puffy, dull face with dry skin. More of it, for myxedema, it is severe case of hypothyroidism. It's very typical: low body temperature, dulled mental processes, congestive heart failure, or in the most severe case, it can be myxedema coma with loss of consciousness, seizures, and slow breathing. Okay, therefore hyperthyroidism, we told that most symptoms are the opposite, but some of them are the same. It is increased heart rate with abnormal rhythm or pounding like palpitations. Remember, in hypo it is possible too. It is high blood pressure or hypertension. It is increased body temperature. It is clamminess, feeling agitated or nervous. It is tremors in the hand, feeling of restlessness even though the person is tired or weak. It is interrupted sleep, frequent bowel movements, sometimes with diarrhea. It is puffiness around the eyes, increased tears, sensitivity to light, or an intense tear. It is bone loss that we named osteoporosis and stopped menstrual cycle. The clinical investigation in the most severe form that we name thyrotoxic storm, thyroid storm, or thyrotoxic crisis. It is life danger disorder. It characterized by confusion, coma, fever, high blood pressure, irregular heartbeat that can be fatal with paroxysm of some ventricular tachycardia with heart stopping. It is jaundice associated with liver enlargement. It is mood swings, muscle wasting, restlessness, shock, and weakness. And one more time, let's return. Pay attention to this picture here. The most specific symptom for thyrotoxic patient, it is eye changes. We name it exophthalmos. Yes, it is eye changes with enlargement and movement of eyes. Okay, here a picture with comparisons of hyperthyroid symptoms and hypothyroid symptoms. Yes, it's shown that they are in most points are the opposite, and comparison them to each other one more time. Okay, and we told that it can be functional disorders like hyper and hypothyroidism, and like another syndrome we have enlargement of thyroid gland, the goiter with obstructive syndrome. And what problems can be found here? It is neck discomfort, it is visible thyroid enlargement or lump, it is discomfort with ties, scarves, tenderness and necklaces, it is hoarseness, it is sore throat, soreness in neck and difficulty swallowing. And one more point, in some cases thyroid diseases and condition can have no thyroiditis. It can be not inflammatory. You should remember about it. Okay, nodules. Nodules usually found in 4-7% in the thyroid gland of all adults. You see how an often situation is it. The majority of nodules do not cause any symptoms. Most people live with their nodules without any symptoms, without any problems till the end of their life. Malignant nodules, which only occur about 5% of nodules, include follicular, papillary, medullary carcinomas, we talked about it, and metastases from other sites of cancer. Nodules are more likely in females, as for all disorders of thyroid. There can be many nodules, which is termed a multinodular goiter, and this can sometimes be a toxic multinodular goiter. Goiter, which is associated with hypothyroidism or hyperthyroidism, may be present with symptoms of the underlying disorder. For hyperthyroidism, the most common symptoms are associated with adrenergic stimulation like tachycardia, palpitation, nervousness, tremor, increased blood pressure, and heat intolerance. And clinical manifestations are often related to hypermetabolism, increased metabolism, or excessive thyroid hormone, an increase in oxygen consumption, metabolic changes in protein metabolism, immunologic stimulation of diffuse goiter, and ocular changes, exophthalmos. You remember those pictures. For hypothyroidism, the most common symptoms are weight gain despite poor appetite, cold intolerance, constipation, and lethargy. They are often non-specific and make diagnosis difficult. Yes, you understood that it can be isolated hyper or hypothyroidism like functional disorders. It can be isolated goiter asymptomatic or with symptoms or of obstruction, some neck symptoms. Or it can be combination. Yes, a lot of cases when we have patient have goiter with hypo or hyperthyroidism with all logical symptoms that we discussed previously. Okay, here are goiter in pictures. Yeah, you see that it can be in different forms. In all this picture, it is very severe cases and very significant enlargement of gland. In the middle upper picture, you see it is cancer. Yes, it's looking of cancer because non-malignant goiter, non-malignant nodules can't look like this. And to last picture, you see that it is a relapse of goiter after partial thyroidectomy. Because the nodules can grow even in small part of thyroid gland after operation, what we see here. Okay, key steps in diagnosis of thyroid gland. Yes, it is clinical examination. During this examination, you're trying to find from history, from objective examination, all those symptoms that we discussed in previous slides. And for confirming your diagnosis when you suspect some thyroid problems, one of the most often it is blood testing. What we are interested in. First of all, it is TSH test. It is free T4 and free T3 antibodies testing to diagnose Hashimoto and Graves' disease. It is testing for reverse T3 levels. Additionally to blood testing, it is imaging of thyroid gland. We can use radioactive iodine uptake test. It is computer tomography. It is MRI and ultrasound to evaluate size, shape and function of thyroid gland. Additionally, we can evaluate size and shape of nodules or lumps and evaluate wherever or not they are suspicious for thyroid cancer and require further evaluation. What further evaluation for today? It is fine needle aspiration biopsy. It's done when thyroid nodules are considered suspicious and need to be tested for possible thyroid cancer. Okay, TSH testing for thyroid dysfunction. For today, TSH is the most sensitive test in an ambulatory population at risk for thyroid dysfunction in the serum TSH. Like a screening, it is enough just TSH level for first understanding if it present or absent some thyroid problem. But for seriously ill patient, for patients with present thyroid disorders, serum TSH is less specific for thyroid disease because the serious illness alone can depress TSH secretion. That's why we need additionally obligatory T3, T4 levels. When an abnormal serum TSH value, even during screening, is obtained, the usual next step is to repeat the measurement of TSH and also measure the serum free T4 level. The most common cause of discordance between TSH and free T4 result occurs in patients with subclinical thyroid dysfunction with high or low serum TSH values and normal serum free T4 result. Serum TSH measurements may yield misleading results for individuals with changing levels of thyroid hormones. Diagnosis of hypothyroidism like a syndrome. The most common cause of primary hypothyroidism is chronic autoimmune thyroiditis, we talked about it, or Hashimoto disease. Other causes are radioactive iodine or surgical therapy for thyroid. Hypothyroidism may occur rarely, less than 1%, as a result of deficiency of TRH or impaired TSH secretion. People with primary hypothyroidism have high serum TSH levels, and the concomitant finding a low free T4 levels confirm this diagnosis. One more time, typical primary hypothyroidism, yes, the most often case, like an example, Hashimoto thyroiditis or Hashimoto disease. The usual it is finding of high TSH level, and based on it we find low free T4 level. It is a criteria of primary hypothyroidism. People with high serum TSH concentration and normal or low normal serum T4 level have subclinical hypothyroidism. It is first stage of hypothyroidism when TSH, like the most sensitive hormone, increased, like a stimulation, hyperstimulation of thyroid gland, but thyroid gland still can do with this hyperstimulation its function and produce nearly normal number of T4. But we always meet that subclinical hypothyroidism after some time go to clinical hypothyroidism. The diagnosis of secondary hypothyroidism, it is rare case, we told, less than 1%, based on findings of a low serum free T4 level and serum TSH level that is normal or low. Hyperthyroidism or thyrotoxicosis. The most common cause it is autoimmune too, but here we name it Graves' disease, with activation of TSH receptor resulting in stimulation of T4 and T3 production and enlargement of thyroid. Other caused a multinodular goiter, thyroid adenoma, thyroiditis, iodine or drug-induced hyperthyroidism, and TSH secreting pituitary tumor. The diagnosis is based on the finding of high serum free T4 level and low serum TSH concentration. Here the opposite, the typical situation for primary hyperthyroidism, like in Graves' disease, it is high serum free T4 and low serum TSH. Occasionally, patients with hypothyroidism have normal serum free T4 and high serum free T3 concentrations with normal serum TSH. We name it T3 hyperthyroidism. It can be rare but possible. Patients with a low serum TSH concentration and normal free T4 and free T3 have subclinical hyperthyroidism, nearly the same situation with hypothyroidism, when changes connected just with TSH in a base of normal levels of T3, T4. Okay, what about visualization of gland? Ultrasound, the most usable method for today. Nodules of thyroid may or may not be a cancer. Medical ultrasonography or ultrasound can help determine their nature because some of characteristics of benign and malignant. It is irregular border It is hypoechoic, less echogenic than surrounding tissue. It is microcalcifications, taller than one shaped on transverse study. It is significant intranodular blood flow by power Doppler. Nodules differ. Ultrasonography is not always able to separate benign from malignant nodules with complete certainty. In all suspicious cases, the tissue sample is often obtained by biopsy for microscopic examination. Here you see picture of ultrasound. It is example of diffuse Hashimoto thyroiditis. It is an ultrasound of 35-year-old female patients. On picture A, it is transverse grayscale ultrasound neck. It demonstrates diffuse enlargement of thyroid glands with heterogeneous echo texture. Multiple tiny and discrete hypoechoic nodules, it showed by small arrows. A few linear echogenic septa by big white arrow are also noted here. At picture B, it is color Doppler sonogram and it demonstrates mildly increased parenchymal vascularity and it is diffuse in all glands due to autoimmune process. Here, ultrasound picture of 50-year-old female patient with colloid multinodular goiter. It is transverse on picture A and longitudinal on picture B. Grayscale ultrasound neck images reveal enlarged thyroid gland having multiple hyperechoic colloid nodules with internal cyst areas. You see by small arrows some structures showing like a ring down sign. And picture C, it is color Doppler that shows increased peripheral vascularity of gland. And here a picture of 60-year-old woman with malignant thyroid nodule with thyroid cancer. Transverse sonogram on picture A of right lobe of thyroid shows particularly cystic tumor with solid internal nodule by arrow and thick walls. Color Doppler sonogram at picture B depicts increased vascularity in solid parts of the tumor. Okay, next method of imagination, it is radioiodine scanning and uptake. Thyroid scintigraphy, it is another name of this test, imaging the thyroid with the aid of radioactive iodine or iodine 123. Radioiodine collects in the thyroid gland before being extracted in urine. A nodule that is overactive, or we name it hot nodule, to the point of suppressing the activity of the rest of the gland is usually a thyrotoxic adenoma, a surgically curable form of hyperthyroidism that is hardly ever malignant. And finding a substantial section of thyroid is inactive, or we name it cold nodule, may indicate an area of non-functioning tissue such as thyroid cancer. A normal quantitation of radioiodine uptake demonstrates that about 8 to 35% of the administered dose can be detected in the thyroid 24 hours later. Here you see a picture of radioiodine scanning and uptake. For example, on picture A, you see a normal gland. It is a mild accumulation of radioactive iodine in the gland. On picture B, you see a much more intensive accumulation of iodine, but it is diffuse in all gland. It's typical for Graves' disease. For toxic disease of thyroid gland, you see radioiodine scan in picture C. And picture D, it is toxic adenoma with accumulation of radioactive iodine, hyperaccumulation just in one place, in place of toxic adenoma. Okay, biopsy. Thyroid tissue may be obtained by biopsy, by fine needle aspiration, or by surgery. Needle aspiration has the advantage of being a brief, safe outpatient procedure that is safer and less expensive than surgery and does not leave a visible scar. Needle biopsies became widely used in 80s, but it was recognized that accuracy of identification of cancer was good but not perfect. The accuracy of diagnosis depends on obtained tissue from all of suspicious areas of an abnormal thyroid gland. The reliability of needle aspiration is increased when sampling can be guided by ultrasound, and over the last 15 years, this has become the preferred method of thyroid biopsy. On these pictures you see the technique of fine needle aspiration biopsy. Yes, it's not too invasive, not too difficult manipulation, and for today it always doing with controlling under ultrasound. And second picture, it is a piece of thyroid tissue under the microscope. It is microscopic picture of autoimmune thyroiditis. Okay, let's start management of thyroid gland. First of all, let's talk on key nutrients for thyroid disorders. Let's talk a little bit about iodine deficiency. Yes, we told that some years ago and still today in some countries, it is the main cause of thyroid diseases. And it has been considered rare in a lot of countries since the last century, largely due to widespread use of iodide salt. Although supplemental iodine may cause symptoms flare-ups in people with Hashimoto disease because it stimulates autoimmune antibodies. Okay, vitamin D deficiency is very important nutrient too. Is linked to hyperthyroidism, Hashimoto's disease, and particularly Graves' disease. The highest concentration of selenium is found in the thyroid gland, and it is a necessary component of enzymes integral to thyroid function. Vitamin B12 deficiency is one of risk factors of autoimmune thyroid disease, so it's important for dietitians to suggest patients with thyroid disease have their levels tested. What about foods, supplements, and medical interactions? There are no specific foods or dietary supplements for people with thyroid gland disorders. The medications can interact with common nutritional supplements. For example, calcium supplements have the potential to interfere with proper absorption of thyroid medications. Coffee and fiber supplements lower the absorption of thyroid medication. Chromium picolinate, it is one of the form of chrome, for blood sugar control or weight loss, impairs the absorption of thyroid medication, and patients should take it 3 to 4 hours apart from thyroid medications. Flavonoids in fruit, vegetables, and tea may suppress thyroid functions. We have such eating like goitrogens. It is cruciferous vegetables like broccoli, cauliflower, cabbage release a compound called goitrine when they are hydrolyzed or broken down. Goitrine can interfere with the synthesis of thyroid hormones that is usually concerned only when coupled with iodine deficiency. Eating cruciferous vegetables denatures much of all of this potential goitrogenic effect. Soy is another potential goitrogen, and is the flavonoids in soy can lower thyroid hormone synthesis. The potential exception is millet. It is nutritious gluten-free grain which may suppress thyroid function even in people with adequate iodine intake. Exercise. What about physical exercise? With hypothyroid patients, exercise can help the weight gain, fatigue, and depression. With hyperthyroidism, anxiety and sleep disturbances are so common, and exercise can help regulate both of them. A structured right exercise program in patients with Graves' disease is showing dramatic improvements in fatigue levels, and significantly more patients are able to successfully stop taking antithyroid medications without relapse. Since fatigue can be a barrier to exercise, it is recommended patients use a pedometer as a tool for tangible source of structure and motivation. Okay, pharmacological management of hypothyroidism. Hypothyroidism is treated with thyroid hormone replacement drugs. The most commonly prescribed thyroid hormone replacement drug is levothyroxine. It is synthetic form of thyroid hormone thyroxine. There is also a synthetic form of T3 hormone known as liothyronine that is sometimes added to levothyroxine 4043 combination treatment. There is a hormone replacement drug called natural desiccated thyroid or thyroid extract. While it has been available for more than a century and it is still in use today, but big researchers show a significant prevalence of levothyroxine treatment against treatment with thyroid extract. For hyperthyroidism and Graves' disease, there are three main key ways that chronic hyperthyroidism and Graves' disease are treated. It is antithyroid drug like metimazole, carbimazole, and propyluracil treatment that can slow down the thyroid's production of thyroid hormone. Radioactive iodine treatment that given in a single dose either in capsule or drink, this shrinks the thyroid, slows down its function and reverses hyperthyroidism. And thyroid surgery or thyroidectomy in some cases, especially for patients who cannot tolerate antithyroid drugs or are pregnant, and radioactive iodine is not an option. As for goiter, it treated according to cause. If thyroid gland is producing too much T3, T4, radioactive iodine is given to the patient to shrink a gland. If goiter caused by iodine deficiency, small doses of iodide in a form of Lugol's iodine or potassium salt solution are given. If the goiter is associated with underactive thyroid supplements are used as a treatment. In extreme cases, a partial or complete thyroidectomy is required. For thyroid cancer, treatment almost always involves surgical removal of thyroid gland. For more aggressive types of thyroid cancers, this may be followed by radioactive iodine treatment to ensure that all thyroid cells are destroyed, a process known as a remnant ablation. Following surgical removal of the thyroid gland, patients are functionally hypothyroid and require lifelong thyroid hormone replacement treatment. Less commonly, other treatments including external beam radiation, chemotherapy, radiofrequency ablation, and percutaneous and ethanol injections. What about autoimmune process and Hashimoto thyroiditis? Integrative and functional medicine practitioners sometimes treat autoimmune thyroid disease, especially Hashimoto's, with the drug low-dose naltrexone. It is opioid antagonist, which may help lower antibodies. Other treatment approaches include supplementation with selenium to lower antibodies. It is the most usable method. It is addressing related adrenal imbalances that may be complicating thyroid treatment. It is dietary changes to reduce inflammation. It is eliminated gluten from the diet due to a connection of it with autoimmunity, and stress reduction and management. Prognosis of patient. Here is the better news. Most people with either hypothyroidism, hyperthyroidism, benign and even malignant thyroid nodules with proper diagnosis and treatment can control their condition with no long-term effects and normal life expectancy. Those with undiagnosed disease may progress to hypothyroid coma or opposite situation, thyrotoxic crisis or thyroid storm, with death rate approaching 50%. Graves' eye disease has been treated with corticosteroid medication, radiotherapy and surgery with varying success. Patients with thyroid cancer have a very low between all cancers mortality rate. It is less than 5%, but the overall risk depends on age, type of thyroid cancer, and the extent of spread of the tumor. Endocrinologists will manage the evaluation and treatment of thyroid cancer rather than oncologists. Prophylaxis. There is no known way of prevent of hyperthyroidism or hypothyroidism. In some countries, iodine deficiency is rare, so it is no way at all. If iodine deficiency is present, it is iodine supplements. Anyway, the iodine is essential for thyroid hormone synthesis. That's why World Health Organization recommends from food, from salt, or from supplements using 90 micrograms of iodine daily for infants and children up to 5 years, 120 micrograms for children from 6 to 12 years, 150 micrograms daily for children after 12 and adults, and 250 micrograms daily during pregnancy and lactation. Radiation will induce both benign and malignant thyroid nodules, we told about it, so individuals should avoid excess radiation or unnecessary CT scans of head and neck. And, important moment, use a thyroid shield when dental X-rays are performed. Here you see all abbreviations from this lecture and the usable diagnostic and treatment guideline. Best of them, it is guidelines of American Thyroid Association Professional and European Thyroid Association guidelines. For today, that's all. I wish you good luck in your study during this year. I'm waiting for your comments and for your maybe questions under this video on YouTube or maybe in our Facebook group of our department. And as usual, I ask for everyone who listening my lecture to leave your name and group under this video for understanding who listening my lecture. Thank you for attention. Goodbye.